So guys, let us talk about ANA pattern in rheumatology. Now, this is one topic which I would probably wouldn't have discussed much for an undergraduate student curriculum, and even I would have omitted in the postgraduate curriculum. The reason for that is in the today's context, especially in the corporate practice and the metro practice, it has not much of relevance because whenever I prescribe an ANA test and if it turns out to be positive, I will definitely ask for the ANA profile to get a detailed understanding of which anti-nuclear antibodies I'm seeing in this particular patient. And the ANA profile, the cost is going down, and also it is becoming readily available even in tier 2 cities. And the network of well connected laboratories, it is making it easier to get an ANA profile done even in tier 3 cities, right? Then why do we need the ANA pattern? The reason we need the ANA pattern right now is for the exams. Okay, and the second thing is when you know the ANA pattern, especially awaiting the profile result, ANA profile result, you can at least gauge what the profile result is likely to show up, right? Okay, so in this video module, we will concentrate on ANA pattern. Now, let us first talk about ANA. Okay, what do you understand by ANA? We all know that ANA means anti-nuclear antibody. So the antibodies that we are detecting are targeting something inside the nucleus. Now, inside the nucleus, there are like a long list of components, right? We have the DNA, we have RNA, we have ribonucleoproteins, we have the enzymes required for synthesis of RNA and DNA. We have proteins involved in channeling of particles in and out of the nucleus. The nuclear membrane is there. There is a lot of stuff inside the nucleus. So ANA may be targeting any of them, right? In fact, it is also considered as a misnomer to call it as ANA because ANA may be even targeting the cytoplasmic components, or there are components which can exist both inside the nucleus as well as cytoplasm, and ANA may be targeting them. But largely these components are inside the nucleus. That's why we call them as anti-nuclear antibodies. Clear? So whenever we use the term ANA, it is a non-specific term. It simply says that there is an antibody targeted at something inside the nucleus, right? But for us to make a good clinical decision, we should also know what specific antigen this ANA is targeting, right? So ANA is a very non-specific term. Specific isotopes against which the ANA may be targeting includes the double stranded DNA. Then we call it as anti-DS DNA. Then we can have anti-Smith, which is also an ANA. Then anti-SSA and anti-SSB, or what we call as anti-Rho and anti-La antibodies. They are also ANAs. Then anti-U1 ribonucleoprotein, anti-U1 RNP antibodies. That is also an ANA. Anti-histone antibody. That's also an ANA. Anti-RNA polymerase 3 is an ANA. Anti-DNA topoisomerase 1, or what we call as anti-SCL70, what we see in patients with systemic sclerosis. That's also an ANA. And anti-centromere antibodies. Centromeres are also part of the chromatin, right? They are inside the nucleus. So they are all ANA. So once my ANA test comes positive, I want you to know that which specific of these ANAs we are talking about, right? Okay, so first let us talk about the ANA test itself. What is the preferred test we do? The preferred test for identification of ANA is indirect immunofluorescence. Indirect immunofluorescence. Okay, so IIF is the preferred test. Okay, and for doing this test, the cell lines that we use is human epithelial 2 cell lines, HEP2 cell lines. What are HEP2 cell lines? These are nothing but cultured cells from the laryngeal cancer. We are using the cancer cells because they are in a highly replicative phase, and it helps us get cells replicated in a quick fashion. So we have sufficient supply of the cells. And the second thing is we will also get at any given point of time cells in different stages of cell cycle. So we can understand or study about that also. Okay, now here we are doing the indirect immunofluorescence using human epithelial 2 cell lines. Okay, and to call that patient as having ANA positive, what should be the titer? The titer to be called as positive is more than 1:80, more than or equal to 1:80. Lesser than that, like 1:40 or 1:20, those titers are not considered as relevant, and they can be seen in up to 5% of general population. Even higher titers like 1:80 or 1:160 can also be seen in general population in the absence of any rheumatological disorder. So we have to keep that in mind. Okay. Now that is a titer, the method, and the cell line that is being used. Now, because we are using indirect immunofluorescence, it is the immunofluorescence pattern that we are interested right now. Why we're interested in the pattern? Because when we ask for the ANA profile, that obviously will tell us which particular antibodies this particular patient is having. But it is also time consuming, and even now, though I said that it is readily available and the cost is coming down, it is still costly affair, right? So when we look at the pattern, we will be able to gauge which antibody is likely to be positive in a given patient, right? So we are using the hep2 cell lines, right? So let us understand the cell first. If this is a normal cell or hep2 cell, whatever it is, it has a nucleus and a cytoplasm, and inside the nucleus there will be nucleoli. The number of nucleoli in hep2 cell line varies depending on what stage the cell is in, so it can be 2 or more than 2. Okay, now when we do the immunofluorescence, it might show the fluorescence activity of the nucleus, right? So when it is showing the nucleus, showing the immunofluorescent activity, basically it's saying that the antibodies are targeting this area of the cell. We will call it as nuclear pattern. Nuclear pattern. Okay. Then instead of the nucleus being immunofluorescent, if the immunofluorescence is affecting the cytoplasm, right, the fluorescent activity is coming from the cytoplasm, we will call it as cytoplasmic pattern. Cytoplasmic pattern. Okay. Sometimes you can have a situation where in the cell, the immunofluorescent activity is only coming from the nucleoli. So nucleoli are the one which are showing the immunofluorescent activity. In such cases, we will call it as nucleolar pattern. We will call this as nucleolar pattern. Okay. Now the nuclear pattern that we are talking about, based on the distribution of the immunofluorescent activity, we have various patterns under that. So one is homogeneous, which previously we used to call it as diffuse pattern, homogeneous pattern. So this entire nucleus is homogeneously showing the immunofluorescent activity. The nucleoli may be spared or involved in the immunofluorescent activity. That is homogeneous pattern, one. Second, you can see something called as dense, fine speckled. So in dense fine speckled, what you will see is inside the nucleus, there are fine speckles or dot-like immunofluorescent activity, and they're all densely packed. Like how I'm representing here, densely packed, almost making it look like homogeneous. So densely packed fine speckles. It is called as dense fine speckled. Okay. Then we also have one more pattern called as just fine speckled. Fine speckled. So in fine speckled, we have immunofluorescent speckling, which is very fine, not coarse or large, but it is little sparsely distributed, not as dense as we saw in the dense fine speckled. Okay, that is third pattern. And the fourth pattern we can see is coarse speckled. Coarse speckled. So in coarse speckled, you will see coarse speckling. And another important point you should remember for identifying the coarse speckles is that in coarse speckled pattern, there is heterogeneity. So there is some region in the nucleus where there are very large speckles and they are like highly fluorescent. Then there is also another region in the nucleus where the fluorescent activity is little low and the size of the speckles may be relatively smaller. So there is heterogeneity in terms of the size of the speckles, also the fluorescent activity of the speckles. That is what we call as coarse speckles. So 4 nuclear patterns: cytoplasmic pattern and nucleolar pattern. Okay, clear? So if we have some idea about the pattern, we will go through these individual patterns and what antibodies are seen if that kind of a ANA pattern is seen on the immunofluorescence. But before that, this table is important. This table only talks about the prevalence of ANA positivity in various rheumatological disorders. And from this table, what examiners can ask you is, in which of the following rheumatological disorders ANA is 100% positive, right? And from the table, you can decipher that there are 3 things: drug-induced SLE, autoimmune hepatitis, and mixed connective tissue disorder. These 3 are conditions where the ANA is 100% positive. And if you are following the classification criteria for SLE, if the SLE is diagnosed based on the classification criteria, then obviously it will be 100% positive, because the classification criteria that we currently follow introduces an entry criteria, right? What is the entry criteria we are talking about? Right, the entry criteria is ANA positivity. So without the ANA positivity, we are not considering the case for classification as SLE. Clear? So ANA positivity, they have also defined the method as indirect immunofluorescence, and they have also mentioned the titer as 1:80, right? Okay, but as a clinician, you're free to make a diagnosis of SLE in the absence of the ANA positivity, because around 3% of the cases can be diagnosed even when they do not have the ANA positivity, and majority of them generally have anti-Rho antibody, right? Okay. Now let us talk about the patterns. The first pattern I'm talking about is your cytoplasmic pattern. The cytoplasmic pattern is seen with the anti-Jo1 antibodies and your anti-SRP antibodies. Now tell me, where do we see these antibodies, anti-Jo1 and anti-SRP antibodies? When I say anti-Jo1 antibodies, I'm talking about anti-synthetase syndrome, right? Anti-synthetase syndrome, which is associated with inflammatory muscle disease, right? Dermatomyositis, polymyositis. And these patients are at increased, whenever they have anti-Jo1 antibody, they're at increased risk of interstitial lung disease, and they're at increased risk of arthritis, and they're at increased risk of developing what is known as mechanic's hand. Clear? So if you go back to the video module on inflammatory muscle disease, you will be able to recollect it. Okay. So this is cytoplasmic pattern. As I've already told you, in cytoplasmic pattern, what we will be seeing? We will be seeing the fluorescent activity mainly involving the cytoplasm and not the nucleus. That is what we call as cytoplasmic pattern. Okay, I've already told you what antibodies we need to remember. Anti-SRP and Jo1. Okay, where do we see anti-SRP? Again, inflammatory muscle disease. It particularly correlates with what is known as immune-mediated necrotizing myositis. And you have to also remember that presence of anti-SRP antibodies in an inflammatory muscle disease patient correlates with the risk of cardiac involvement. Clear? Okay. Now, the second thing I'm talking about is nucleolar pattern. Okay, nucleolar pattern is where the nucleoli show fluorescence. So only nucleoli are the one which are showing fluorescence. That is what we call as nucleolar pattern. Nucleolar pattern. Okay, so what are the antibodies to remember for nucleolar pattern? The first one is anti-PM-SCL antibody, and the other one is anti-RNA polymerase 1 antibody. Now, where do we see these antibodies? Especially, I want you to remember anti-PM-SCL antibody, which is seen in overlap syndrome involving polymyositis plus scleroderma or systemic sclerosis, right? PM stands for polymyositis, SCL stands for systemic sclerosis. Okay, these are nucleolar pattern. Okay, then coming to one pattern I forgot to mention, that is centromere pattern. Okay, so in centromere pattern, what you see is, in the centromere is part of the nucleus only, right? So in a interphase cell, when the cell is not dividing, we know that the genetic material or DNA is not aligned in the form of chromosomes, right? It comes into picture when the cell is ready for division. So the chromatin is diffusely distributed. So the centromeres are also diffusely distributed inside the nucleus. So what you see is, these antibodies, when they attach to the centromeres, you will see inside the nucleus there are diffuse speckled kind of pattern. Okay, but the same when you look into a cell which is in the metaphase. Okay, so let me say that this cell from the same study is in the metaphase. So in the metaphase, what happens is, in the metaphase, the chromosomes are all aligned at the center of the cell, right? So all the centromeres form a central line. Okay, so if all the genetic material is getting aligned at the center of the cell in the metaphase, then all the antibodies, their fluorescent activity will also be concentrated on the center of the cell. So all the speckles or dots that we were seeing here in the metaphase cell, the dots will all be centered in the center of the cell. This is what we call as anti-centromere pattern. And where do we see anti-centromere antibodies? This is what we call as anti-centromere pattern. Where do we see anti-centromere antibodies? Yeah, you all know, right? We see that in patients with limited cutaneous systemic sclerosis. So anti-centromere pattern is seen in limited cutaneous systemic sclerosis patients. Okay, this image kind of makes it easier for you to identify. So this is a nucleus. The cytoplasm is not stained, so we don't see anything in the surrounding. And all the dots you're seeing, those are the points where the centromeres are being attacked by the antibodies. Now this is one cell which is in the metaphase. Okay, and you can clearly see that all those dots are concentrated at the center of the cell. The cell outline will be something like this, and all of the fluorescent activity in the form of dots is concentrated on the center of the cell. This is what we call as anticentromere pattern. Okay, so that is seen in case of limited cutaneous systemic sclerosis. Okay, now we come to the nuclear pattern, right? What are the patterns we have discussed so far? One is homogeneous pattern. The second one we discussed was dense fine speckles. Third one was fine speckled, and the last one was coarse or large speckled, right? So let us see the individual ones. The homogeneous one is where the entire nucleus has taken homogeneous stain. So all this what you're seeing here is a nucleus, and it has taken the fluorescent activity uniformly. This is what we call as homogeneous. Previously this was called as diffuse. Nowadays the term is homogeneous, and this pattern is seen with two antibodies mainly. The first one is anti-dsDNA antibodies, and the second one is your anti-histone antibodies. Okay, I don't need to really tell you what these antibodies correlate with. Anti-histone correlates with the drug-induced lupus erythematosus, and anti-dsDNA antibodies, yes, it is the second most common antibody in the patients with SLE. This is the second most specific antibody after anti-Smith in patients with SLE, and this is the most useful antibody in patients with SLE because it correlates with, number one, it correlates with the disease severity, disease activity. Number two, it correlates with the risk of lupus nephritis, right? Okay, so this is one antibody which can be used for prognostication in patients with SLE. Okay, that is homogeneous pattern. Then I told you dense fine speckle, right? So in dense fine speckle, what we see is you will have speckles throughout the nucleus, but they are very fine and they are quite densely packed. Okay, so you can see that in this cell, it's very difficult for you to say where is the speckle present. They are very fine speckles and they're densely packed. Whatever black zones you're seeing, they are nucleoli. All these are nucleoli. So keep that in mind. So here in this particular sample, the nucleoli are not being stained. Okay, so this is what we call as dense fine speckled. And for the sake of exam, just remember that it is often seen in normal individuals. We don't have any pathological association with this as of now. Okay, so if I get to know that this patient is ANA positive and the pattern is dense fine speckled, I'm a little relieved because it is often suggestive of a normalcy rather than a pathology. Okay, those two patterns addressed. Now we have fine speckled and coarse speckled. Fine speckled is where you will see fine speckles inside the nucleus. The speckles are relatively less sparsely, they're relatively sparsely distributed, less densely distributed in comparison to dense fine speckled. Okay, so in which conditions you will see these antibodies? We see these antibodies in anti-Rho or anti-La type of ANA. Okay, anti-Rho, anti-La, and then third one I want you to remember is anti-TIF1 gamma. The fourth one is anti-Ku, and the fifth one is anti-Mi2. Okay, now tell me where all you see these conditions. Anti-Rho, anti-La, the Sjogren syndrome, whether primary or secondary. Then TIF1 gamma, we see that in patients with inflammatory muscle disease, and it particularly correlates with what? Cancer associated inflammatory muscle disease or dermatomyositis or polymyositis. TIF1 gamma correlates with cancer related inflammatory muscle disease, right? Okay, then anti-Ku again we hear in inflammatory muscle disease, and anti-Mi2 particularly, it's like something that I want you to remember. Anti-Mi2 correlates with dermatomyositis. I'm not saying the bland word inflammatory muscle disease. I'm very specifically talking about dermatomyositis because this anti-Mi2 is specific for dermatomyositis, and it also correlates with a relatively milder disease. So these patients with dermatomyositis with anti-Mi2 antibody generally have mild disease, and there is lower risk of interstitial lung disease if you have the Mi2 antibodies. Okay, so this is fine speckled. In the coarse or large speckled, you will see that there are multiple large speckles throughout the nucleus. All the unstained black zones are the nucleoli. Okay, and you can also agree with me that there are some areas where the the fluorescent activity is low and the speckles are in small size, and there are areas where speckles are in large size. So there is a heterogeneity in terms of the fluorescent activity and the size of the speckles. This is what we call as coarse speckled. Okay, now the important antibodies that can give rise to coarse speckled pattern are: number one, your anti-U1 RNP antibody, and number two is your anti-Smith antibody, and number three is your RNA polymerase 3 antibody. Okay, now where do we see anti-U1 RNP antibody? We see that in patients with anti-U1 RNP, we see that in patients with mixed connective tissue disorder. Anti-Smith, like we all know, the most specific antibody for the SLE, and anti-RNA polymerase 3 we see in systemic sclerosis patients, right? So whenever I see a coarse speckled pattern, I start thinking of possibility of the mixed connective tissue disorder or an SLE or the systemic sclerosis. Whenever I see a fine speckled pattern, I start seeing the possibility of Sjogren's syndrome or the inflammatory muscle diseases. Whenever I see a homogeneous pattern, whether drug induced or not induced, I start thinking or contemplating the possibility of SLE. And when I see dense, fine, speckled, I would be less likely to think of SAR, any systemic autoimmune rheumatological disorder. Okay. If I see the anti-centromere pattern, I'll be thinking of limited cutaneous systemic sclerosis. And if I see the nucleolar pattern, one of the possibilities I can think of is overlap syndrome involving polymyositis and systemic sclerosis. If I see a cytoplasmic pattern, possibly I'll start thinking of the inflammatory muscle disease, particularly anti-Jo1 suggestive of anti-synthetase syndrome or anti-SRP suggestive of immune-mediated necrotizing myositis. Clear? I hope you have a clarity about the patterns now. So basically, when I say pattern, it is the immunofluorescent pattern, and we are only getting rough guess or rough clues about what antibody could be there as a reason for ANA positivity. But a definite answer is only possible when you get the ANA profile done. Clear? Okay. So before we wind up, just a quick recap of whatever we have learned. Homogeneous pattern, double standard DNA or antihistone antibodies. The nuclear pattern, that is dense, fine speckled. I have told you to remember it as a normalcy. Anti-centromere, obviously, your limited cutaneous systemic sclerosis. Then nuclear pattern with the fine speckles. I have asked you to remember anti-Rho and anti-La, Mi2, TIF1 gamma, and anti-Co. Clear? Okay. Then the last one is the nuclear pattern with large or coarse speckles. I have asked you to remember U1 RNP for mixed connective tissue disorder, RNA polymerase for systemic sclerosis, and anti-Smith for SLE. Clear? So these are the important things we need to remember from this topic. So with that, I'm signing off, guys. I'll be seeing you in the next video module with next interesting topic. Till then, have a good time, guys.